So hello, everybody. It's my great pleasure to speak here today, and I have decided to give a talk that is a bit more of an area overview talk, not so much the research that my lab in particular does, but more, trying to light incite some sparks of thoughts around the area of artificial intelligence and how it is affecting healthcare. And I figured I should call this talk the good, the bad, and the ugly. It's not because I am a particularly large fan of Western movies, also not because I was even born when that movie came out, but because I like witty titles. So I thought this would probably be a good way of luring you into today's meeting. So let's start by giving you a bit of an overview of why we should care about this. So trying to make the case for AI in healthcare. So you may know that in the US, there are gaping divides in health system performance. So when we characterize the performance of different healthcare systems, hospitals, primary care providers, and whatnot, there are certain metrics that you can look at, readmission rates, overall complications, and so on. And there are studies that run every year or regularly to quantify that across the US. And what you will find is that there are gaping divides in the performance across the US, with the coasts usually doing quite well, and then the Midwest not so well. And this is true for the US, but it is also true and even more dramatic on a global scale, where, if you look at this, you think twice where you want to get sick, right? If of course no one wants to get sick. But if maybe the coasts are a good place. Now, why does this happen? Well, so the issue is that medicine and treating for diseases is very complicated. And there is a high variability in what is right? What is the right diagnosis? What is the right treatment? What is the right decision? And what is the right decision in a specific patient's context, right? So all of that is very high variability, which means that it's very difficult for individuals to make the right call every single one of the time. What that means is that you are more likely to be right if you have large experience, right? How do you get experience? Well, by lots and lots of training and by being specialized. So you're not treating every possible condition, you only treat a very select few, and you do that for a very long time. You receive lots of training. After university, you go to residency. After residency, you go to fellowship. And at the end, you are become an expert in that specific domain, but not everywhere else, right? And then you can treat that very, very well. But those people that are this highly trained and that can serve that specific patient population very, very well with high expertise, they cluster. And they cluster at places where there is good stuff, right? Hopkins, at the coasts, and so on. Maybe not so much elsewhere. And that's bad. That's particularly bad because it means that we have a problem of equitable access to highest quality healthcare. So in principle, we know how to do it, but there are a select few that can deliver that care, and not everyone can do it. Not everyone gets access to it. So what can we do about this? One way of dealing with this, of course, is political, but we're not politicians. We're not in law. We're engineers and computer scientists. And one solution that we can come up with is try to develop algorithmic solutions that somehow assist clinicians to deal with this variability in outcomes and deal with this variability in patient presentations, and supporting their decision-making in an attempt to level this playing field, right? Equitize the access to care nationally and globally. Now, how does AI factor into this? Well, artificial intelligence, the way how we currently like to think about it, is essentially a class of algorithms that some of them learn from experience, which means that we can just feed them with a lot of data. They will discover policies that are optimal with respect to some metric that we may care about. And then they can perform, in some cases, on an expert level, fully autonomously. And that seems like a great idea. And indeed, in some cases, these algorithms have very tangible outcomes to improving the care that is being delivered in our primary care facilities and healthcare centers. So I should start with some examples of the good, right? One thing that these algorithms, AI algorithms right now, can do particularly well is they can analyze images. One image that you would like analyzed, for example, is CT scans of trauma cases, for example, in cases of trauma to the head. So people present to the emergency room. They are being, well, there's an anamnesis, so they describe their problem, and they are being fed into a CT scanner where they take a tomographic image of the head, which is a three-dimensional representation. And then a radiologist, which is a highly trained expert, reads those images for potentially actionable findings, right? Whether this person needs to receive treatment right away, for example, in the case of stroke, or whether this is something that cannot be treated immediately. There's maybe swelling, there may be other things that need to settle in first before treatment can happen, right? So there is a certain discrepancy between very, very urgent cases that need to receive treatment as quickly as possible and others that are routine that may take a longer time for the clinicians and radiologists to read the scan. Now, right now, the way how these scans are being read is on a first in, first out basis, which means that you have a queue and that queue just accumulates as people present to your scanner room. Now, that is not necessarily appealing because it means that for some cases that potentially need immediate attention, they are being seen later on in that queue. And this is where an algorithm like this that can interpret these images and has learned something about appearance of very important features can help, because it can automatically in the background analyze these images and reprioritize the reading queue by essentially selecting cases that have actionable findings and may be urgent and putting them on the top of the reading queue, right? So that means that for some of the cases, you read them much quicker, which essentially reduces the time from presentation to diagnosis for those patients. And in this case, they have been able to demonstrate that doing this shortens the time by 12 minutes approximately for people to get the diagnosis that they would need in order to receive care that in the case of stroke saves brain. So this is certainly an exciting area. Another research project that's been going on, this is led by Google, is an AI-infused microscope where essentially we're now moving towards quantitative microscopy, where we take images that are very, very large and very high magnification, right? Where you can get overview pictures like this, but you can essentially zoom into there, right, to the individual cell level. And we want to get away from a qualitative description of what a pathologist sees here and go towards quantitative description of what is going on in that specific area, right? One of those quantitative metrics that you could think about, for example, is a mitotic cell count, right? So how many cells are currently undergoing mitosis in a specific area, which is indicative of the malignancy of breast tumors and breast cancer. Or you would like to measure the foci of individual tumors in cancer of the lymph nodes. All of those are things where you need to first interpret this large amount of data, find it in the image, go in there and perform the measurement manually. And here, combining this microscope with an AI-infused algorithm that essentially detects in the image while we process it areas that are known based on data that has been analyzed previously, that is known to correlate with cancer appearance, and essentially simply provide a heat map or outline of the areas that require manual analysis, simply guides the pathologist in their assessment and essentially remove some of the variability that people may suffer from by analyzing the whole image, being overwhelmed with that. Well, are those the only cases? Well, no, not really. There you can find very positive and encouraging examples of recent advances of AI in healthcare that somehow shape the whole spectrum, from public health and wellness measures and mobile health, where essentially we now have the Apple Watch that is FDA cleared to detect atrial fibrillation, and neural networks that are able to forecast adverse cardiac events from ECG signals into the future. There are novel methods that combine computational methods with machine learning and AI technology to essentially perform gene expression profiling to provide personalized treatments. There are digital twins that model on a patient-specific basis the anatomy in order to select the most applicable treatment options. There are quantitative measures to predict infarction, predict sepsis onset, and perform automated measurements in order for quantitative medicine to succeed in practice. And then there is a lot of research going on in the medical field, where we now pioneer drug discovery and perform interventional guidance, like, for example, in treatment planning with data fusion and guidance, including augmented reality. There is intelligent imaging, and we do activity recognition and skill assessment for automated training, for example, in robotic surgery. Now, all of these things are exciting, and we can clearly see how the digitization of medicine is advancing, and how we're really moving from something that is very strongly qualitative to something that is data-driven, personalized, and quantitative. Now, there are a lot of challenges to achieving this transition, and I will talk about one specific example here that I will call an example of the bad, as one example where further research is necessary, or some things that are happening here. One thing that we know is that if there is one thing that is particularly effective in developing AI algorithms that work particularly well, then it is data. Unfortunately, most of the things that we hear being talked about is not actually the data sets. Really, what we hear talk about is how the GFLOPs of GPUs scale, how NVIDIA is releasing the new GPUs, and that are then sold out pretty much everywhere, how our network is increase to up to 150 layers of depth, and so on and so forth. But what has stayed the same is about the data sets. But really what we need to do is we need to think about the data that we're using and that drives this change. So in general computer vision, we have reasonably established benchmarks that suffer from their own problems, but they are pretty large to begin with. So we're talking about 1.2 million instances that can be used to train these AI algorithms. Now, what do we have in healthcare? So in healthcare, you will find that it varies quite a bit by the specific application group that is writing the paper or doing the study. And the instances range from lower than 100 instances to a couple of thousands if you have a big data set, right? It's not comparable to the computer vision data sets that are in the millions. Now, clearly that has sparked a lot of interest and a push for creating challenge data that is publicly available and enables a more broad and inclusive community to think about developing algorithms for the advancement of healthcare. Right now, we know these chest X-ray data set that has 200,000 images. There is the MIMIC data set. There is a brain tumor segmentation challenge that is called BRATS. And all of this is great, but there is a big issue. And the issue that comes with this is that due to the availability of data in very siloed research areas, a lot of the current advancements of AI in healthcare is focused onto these challenges where accessibility to data is not an issue. And that essentially means that we're making a lot of advancements in some specific areas, for example, the automated analysis of chest X-rays, but we're not really advancing other areas where findings and improvements in general in AI and computer vision could lead to much better outcomes, would have more potential for translational research and affecting healthcare and the quality thereof. So really the question is, what are the fundamental problems in this healthcare space that we need to be innovating in with machine learning and AI techniques? And how can we drive meaningful change? Because really the question is, where is this opportunity, right? Where an algorithm like this that can provide some form of automation really flips the switch from something that previously was unsolved to something that is actionable, like the example that I showed you on reprioritizing the learning queue. So the real question here becomes then, how can we develop solutions for the most important problems, which includes a whole lot of research questions like the ones on how can we deal with the fact that for many problems that we care about, we only have access to very limited data? How can we deal with the fact that in many of these problems, the data that we will be getting may not be representative? And how can we work together with clinicians and other people to identify the most important problems and possible actionable solutions, right? And this will involve people like you, the next generation, that understands this space and, you know, is interested in research at the intersection between healthcare professionals and computer scientists, engineers that know how to develop these solutions. Now, this already set us up a little bit for why I decided to talk about and split my talk in this specific way. It's because there is a lot more research opportunities, and this brings me to the few cases of the ugly that I wanted to discuss here. I will try to motivate those cases here at one specific example. The example that I have selected here is an example that appeared in a very prestigious journal. It appeared in Nature. And essentially, it claimed dermatologist level classification of skin cancer using deep neural networks, which is one machine learning AI technique, essentially. I want to be very clear about this. I don't use this example because I feel like discrediting the authors. This is great work, and it has been paving the way for a lot of research to follow. It just shows how complicated doing this properly is, and why we need to have a lot of bright brains in this area to really make sure that we're driving change meaningfully. Now, what they did is they trained this machine learning algorithm exactly like I motivated this in order to stratify and take the variability out of how these skin lesions are being classified, right? So now it doesn't depend on the clinician's expertise, on the dermatologist's expertise. It's an algorithm that analyzes these images. Right, so irrespective of where you deploy this algorithm, potentially it would perform the same on the same level, and it would perform very well. So the diagnosis and the diagnostic accuracy that people would receive is consistently high. Wonderful, right? They also showed that this algorithm even outperforms dermatologists. So that sounds pretty good, no? So why did I not mention this in the beginning? Well, so if you look at these images that I have shown here, if you look very closely, you will notice something. And the thing that you will notice is that on these images here that are malignant from the database that was used to train this, you will find these small, these small patterned artifacts there, which turn out to be rulers. Okay, why should we care about this? We care about this because the images are taken from the practice of dermatologists. And dermatologists, if they have a suspicion that potentially a lesion may be cancerous, they put a ruler next to it, because next time the patient comes back, they put it back again and they measure the size. If there was a substantial change in size, growth, then that is usually very indicative of a malignant lesion, right? So what that means is that in turn, having a ruler next to a lesion leaks information that a dermatologist, a trained expert professional, already believes that this is very likely malignant. So this means that there is a bias this means that there is a shortcut in decision-making accuracy, right? If there is a ruler, you're much more likely to see a malignant lesion. But this is not something that you should be assuming in practice, right? This is a correlation based on an artifact of how data was generated. It's not really a cause in that specific case. And this is one of the big issues that right now we're dealing with, not only in this specific example, but in lots and lots and lots of other examples as well, where our current understanding of machine learning technology is very heavily dominated by association and correlation, which is very, very different from causation, which essentially introduces potential biases, shortcuts in the mapping from inputs to outputs that essentially prevent generalizable and robust learning from this data that we're getting, right? So you can see that we will need to somehow deal with this algorithmically to make sure that we discover the mapping that we actually care about, not some artifact of shortcut. Okay, so now I'll show you all these images. Notice anything else here? Charlotte, please go ahead.
I noticed someone else already said in the chat too, the skin color all seems somewhat similar.
Yeah, wonderful, wonderful, exactly, right? So the skin color of all of these images is pretty much white. So what does that mean? Well, the data currently is generated based on how the data is being generated, and by people that go to dermatologists for regular checkups of their skins and of their skin lesions. That is a very specific set of people, because some people may not have access to that level of care, maybe due to their overall healthcare plans, maybe due to other reasons. But what it means is that the overall data sets that will be available for generation of these learning-based models that rely on representative data sets are going to be biased to the data that is representative in that current way. So how do we develop algorithms that are fair for the general population based on biased data, right? This is clearly some aspects that we need to work on very hard, and that I think that you are uniquely poised to think about. Notice anything else? Because we're running out of time, I will tell you. So here's the idea, right? The idea is that this is an algorithm that can be deployed anywhere, anytime, by people that don't necessarily have the same knowledge as the dermatologists. But it was dermatologists that took these images that were used to train it. So now if I take my smartphone and try to photograph a lesion on my skin, it will look like this, right? This or this. It's a bit different, right? It's not as crisp because the smartphone is not really a dermoscope. It's not meant for close-up images of skin lesions, right? So the images may look completely different. And we know, well, I know, and I maybe you also do, is that the current algorithms that we develop this way for image analysis are particularly brittle to those pixel level characteristics. So if you have an algorithm trained on very sharp images, if you were to deploy it to something like this, the behavior would very likely be much closer to random performance than it was on the previous database. So there is really no way of making sure that this algorithm would work. So why does it matter? It matters because if you were to deploy this algorithm, knowing that it would expect very crisp images, but the user provides an image like that, there is no way that the user would have an understanding that the output, the recommendation of the algorithm, is likely wrong, right? So what we need to think about here is we need to think about the anticipated use case in mind. We need to think about the user that will likely go in and use that data set, use that algorithm with a smartphone, with a dermoscope, whatever it may be. And ultimately, we need to design for the target population and with the user and humans that are using it and are, well, using the technology and the technology being used on in mind, right? And that is diverse. So a couple of concluding remarks here is that in general, what I've tried to convince you of is that AI and machine learning will certainly become more important in healthcare and will transition into one tool that is being used across the board in order to bring into life evidence-based medicine that can allow you to cater personalized decision and treatment support on a patient-specific basis. And all of this we do because of this hope that we will be able to have more equitable access to the highest quality healthcare that right now is not as accessible and very costly. But I also think that there is a long way that we have to go. The one aspect is the AI and ML readiness of our overall system, where we need to find better ways of getting access to data, and particularly the meaningful data, have systems that are designed for the use of artificial intelligence and machine learning techniques in mind. And we need to think about processes. How can we legalize this? How can we make sure that the use cases are ethical and that the performance of the systems are properly vetted in order for them to be well justified? We need to think about the brittleness, and we need to overcome the challenges to brittleness of the contemporary systems that are very strongly based on associations and correlations that may essentially exist on the pixel level, right? So that even something as simple as noise injection will completely destroy the performance of your system. And finally, I think we need to think about how we can design these systems for a diverse population of users and patients, and how we can make sure that these systems are fair and used ethically. And I think that in that regard, it is really important that the stakeholders, both of the people that use it and the people that develop it, are inclusive and a diverse community. Therefore, I would like to invite you very strongly to come and be part of this conversation and engage in this type of research. I think you will have a lot of fun. That's the end of my talk. Thank you very much for your attention, and I'm open for questions.